Okay, next injury that we're looking at for the shoulder is going to be an impingement syndrome. And the first thing we have to get is understanding the definition of impingement. That is compression of tissue, usually between two osseous structures that we're looking at. And impingement can mean one of three things, okay? Typically, it will be supraspinatus or biceps brachii, which is why I've selected this image right here. But it can also be an AC impingement. And you'd only notice that at the very end of your range of motion, at the very top. This painful arc doesn't really help us very much, but I want to get through some of the basics first before I go into more detail. So who gets impingement syndromes? Well, it depends on the stages. According to NEAR, you can be looking at stage 1, usually under the age of 25, and then stage 2 into 25 to 40 as the tendinopathy evolves a little bit. And this one is a little bit more difficult to reverse potentially. And then stage 3 over the age of 40, now you're seeing more significant changes, even degenerative changes occurring around the joint. So I put it through any age group, again, male greater than female, but more current research might suggest that this data is normalizing as we compare activity levels. Prior injury, number 1, overhead activities, and then any kind of throwing or movement. But it starts off as dull, achy pain in the shoulder, worse with shoulder abduction. Ask about sleeping position. This is extremely important. People always forget to ask about this. If you are not sleeping in a good position, or you're sleeping compressed on that shoulder or arm above head, or even better yet, over to the side like this, all of that can aggravate these impingement syndromes if you're thinking of a couple of hours laying in that position at night before you switch positions. So always asking about sleep position. Check for muscle atrophy, asymmetry, of course, warmth and swelling. Pain on top of the shoulder. This gets back to the sign language of injury. If it's an AC injury, pop this jacket off. If it's an AC injury, what am I doing? I'm showing you pain over the top of my shoulder right here. If it's biceps tendonitis, I'm going to give you a linear line down the front like that. And if it's an AC injury, a supraspinatus injury, you've got to watch it because you can confuse that with an AC. Supraspinatus will often refer over the lateral deltoid a little bit, and then they'll try and reach underneath their acromion, actually where the site of compression is. That is hugely diagnostic for you right there. Now, range of motion, active range of motion, the best thing to look for is this painful arc right here. Between that 80 to 120, again, it can start earlier or later depending on the person's specific presentation, but that'll be the main thing that we look at. Passive range of motion is usually okay unless you compress or stretch the damaged tissue. And we see that more specifically with the special tests. And then we get into neurovascular screen, should be within normal limits. If there is numbness or tingling or weakness, then I'm looking at a cervical radiculopathy, maybe a different presentation of a thoracic outlet syndrome type thing, or some kind of nerve entrapment issue. Difficult to diagnose specifically because it is so similar to other shoulder pathologies. And this is the one that often gets misdiagnosed as a rotator cuff strain. Well, is it a rotator cuff strain, or can we be more specific than that? Okay. Special tests, impingement sign is great. NEAR sign is great. If it is a biceps long head, direct palpation is actually pretty good as well. And for supraspinatus, I love using Hawkins-Kennedy. It really grinds that acromion in right there. So again, videos of these tests are available on the website, or you can go ahead and look at the physical assessment text as well. All right. Arm drop test for a supraspinatus potentially, but not my number one go-to. Empty can is going to be better. Diagnostic imaging, usually not needed for this, but you can look at ultrasound and x-ray potentially to see potential issues there. Another interesting one, there's some research on talking about injection of local anesthetics, and you can apply this anywhere in the body. So if somebody has an injury and you can give ultrasound guided injection into what you think is the damaged tissue and it gets rid of the pain, you are probably in the right area of damage. All right. Management. What are we going to do for this impingement syndrome? Well, number one, we're going to recognize the painful arc position right here, anywhere from roughly 45 to 120, even up to 150 potentially. But management is going to be biopsychosocial support. What are you doing in your activity? Can you modify your activity of daily livings in your job and still earn an income and continue to be a productive member of society and actually afford to feed yourself and your family? Pain reduction and avoidance activities, absolutely. Meth, NSAIDs, biggest one, and we heard this from Santa, ensuring proper warm-up before you begin, okay? Proper warm-up. And then one of the simplest warm-ups you can give are going to be these simple Codman arm swings right here, okay? Codman arm swings. That's what they're called. Basically a pendulum exercise, swing your arm around in circles, or even taking that dowel rod that we all keep in our office and moving around from side to side, moving the shoulder up with minimal muscle contraction to show the range of motion. Treatment options, there are fantastic treatment options here. I would go for warm hydro in chronic cases. Manual lymphatic drainage can be there. You can look at Swedish, Petroslage, Effleurage, PNFs are all going to be there. One of my favorites still, hand over hand, follow the actions that I do with the patient, moving back and forth, trying to find them in different ranges that don't cause pain. Instrument assisted techniques, I'm a big fan of for this area as well. Mobilizations, now this is an area where I would start to mobilize in a little bit more into glenohumeral, AC joints, and of course, areas of compensation, cervical, thoracic, and ribs. Again, electrotherapies, TENS for pain reduction, potentially. Ultrasound can be there. Even high intensity laser therapy has some good research on it, potentially as well. Acupuncture or acupressure points can be used, pretty much the same ones that we've used for chronic pain issues. Surgery, last resort for open arthroscopy that might be done. Resection of the clavicle, like these are major traumas to the body. These surgeries are not usually needed. Go ahead, Sydney. What do you have for us?
Do you know roughly how well like the ultrasound and laser like works? Like I know you said there was good research, but like specifically for the ultrasound.
Yeah, I haven't looked at this stuff in probably about 5 years, so my memory will be out on it a little bit. The issue for all of these, the ultrasound and TENS is pretty good research for just general pain reduction. Ultrasound itself actually has pretty controversial research on it. Sometimes it works, they show that it works. Sometimes they show that it doesn't work that well. So it's really on a case-by-case basis. The last study I can vaguely remember was just at a high-intensity laser therapy and offering potential benefits, but these are so far gone in my mind, I'd have to do a quick literature review for it. They wouldn't be my first go-tos on this case either, unless the pain reduction was for TENS to help you get you sleeping better or functioning better. Like, I mean, it's not something I would go to for, again, long-term use, just short-term application typically.
Okay, yeah, because I think like up in the clinic, this is kind of like something that they tend to jump to very quickly. Like, oh
yeah, and that's
let's do laser and ultrasound.
Yeah, and that could be a downfall for a lot of people. If you look at the research, it's kind of controversial around those. Ultrasound and a lot of the electrotherapies, you'll see that it's a go-to for a lot of physiotherapists. Literally, you show up into the clinic and let's hook you up to the electrodes and let you go. And for a lot of patients, if you look at anecdotal levels, they're like, it didn't feel like it was offering me any benefit. It wasn't changing my symptoms or my progression through this condition. Therapists will do it because it's a nice way to go in for serial visits, one after the other. And there's docs and chiros who do it as well. So it's not just physios. If you're looking at the high level treatments that I gave, and I'll go back to that graphic here that I did at the start. If you look at this graphic that we were talking at the start, you don't see electrotherapeutics on it. Okay. If you look at the bigger studies, the more evidence-based studies, they don't really support the use of the electrotherapeutics. I put it in there as an idea for a lot of people, and there are smaller studies that do support it. But the issue is that you ultimately are going to have to figure out what you can do on that day with that person, getting over your own biases as the clinician or what they prefer. Some people swear by it. They've had ultrasound before and they're like, oh, this works great for me. Whether it's real, whether it's a placebo effect, it doesn't matter. If they feel like it works for them, great. But I wouldn't jump to it as my first go-to. I would be back here with my go-to general measures, and then I would follow that graph around right there. But really good question, Sydney. I don't know if I really answered it for you, but that's my kind of take on it.
Yep, that's good. Thanks.
Yeah. All right. Okay. Next thing is going to be follow-up, ensure proper warm-up, acute goals, relieve pain and inflammation are going to be there. And then you're going to go into more subacute, normalizing range of motion, prevention. You are going to do biomechanical evaluation. So for my elite badminton player that I'm treating right now, we had her bring her badminton racket in and we're going through what does her swing actually look like, looking at the mechanics of it. And believe it or not, we're making her swing with her non-dominant arm as well. Okay. There is research that supports treating the unaffected side and working on mechanics and increasing muscle strength on the unaffected side can have effects on the affected side. In the muscle manual, I write about that, where I talk about muscle strength training gains. There's one study that talked about a 30% Bilateral strength gain by treating the unaffected side compared to the affected side. Avoid sleeping on a hard mattress or positions that the shoulder is abducted overhead, okay? And prognosis varies on coexisting factors. Do they have instability, arthritis? How long have they had this for? Most simple cases resolve relatively quickly and should resolve within this 2 to 6 weeks area right here. Most of your healing has taken place within that time. Complicated cases can take longer, and always get a secondary opinion if you are looking at complicated cases where imaging might actually be warranted, okay? But in the vast majority of cases, imaging is not warranted.